is highly successful procedure with a proven long-term results augmented by robotics and navigation. So indications, vast majority of indications are isolated grade 4 medial osteoarthritis, requires functional ACL, that is classically they told it requires to have functional ACL, and all the other things have been tried. So requirement ACL PCL intact for the stability and kinematics, contralateral OA should not be there, deformity should be correctable to neutral like varus 10 to 15 degree, less than that flexion deformity 5 degree to 10 degree, and should have at least 90 degrees of knee flexion and localized medial compartmental osteoarthritis. So for example, this patient on the other side, if you see, if you take X-ray, medially there is reduced joint space, there are cyst formation, medial posterior meniscus tear, and bone on bone disease. This X-ray is standing X-ray. If you take Rosenberg view, still we will get the clarity. So there should be good alignment. You cannot do high tibial osteotomy. You cannot just do medial meniscus procedure. You cannot do, you don't have to do total knee replacement because he is 42, 45 years. So these are the patients whom you can think of this procedure. If you take Rosenberg view, you will still get more reduction in the joint space, and then our decision making will be have more clarity. So, and further extended indications like AVN of the particular compartment or valgus knee with the lateral compartment and patellofemoral. So re-evaluating. So age is no longer strict contraindication now. Obesity, the recent studies suggest more than 35 BMI, less than 35 BMI, results are comparable. However, for our clinical practice, I feel 85, 90 kg or less than 35 BMI, you should choose these kind of patients if you are considering partial knee. So standing long leg films, standing 45 degree flexion views, stress views to confirm the integrity of MCL, LCL, and advanced imaging like MRI scan. So isolated, correctable, ACL intact. However, for mobile bearing, for fixed bearing, ACL deficient knees without any like copers, we have the copers who are coping up without ACL, still can go ahead with the we can go ahead with the partial knee replacement. In contraindications like inflammatory arthritis, active infection, and ACL insufficiency is theoretically not to be operated for. So again, relative contraindication, non-correctable deformity, like we extend our indications as surgeons, like 15 degree non-correctable deformity, some people still do partial knee replacement and say that it works. But for our for the classically, we are not supposed to do for this partial knee replacement. If fixed deformity of flexion, fixed varus, and reduced stiffness of the knee less than 60-70 degree. So there are fixed bearing and mobile bearing. So fixed bearing is the polyethylene locked to the tibial tray, less technically demanding, localized where lower risk of procedure technicality wise. And the mobile bearing is these are the steps: excision of osteophyte, tibial plateau resection, femoral drill holes, femoral saw, and we classically equalize 90 degree and 20 degree because extension, full extension, there will be stability by the collateral. So balance in 20 degree was classically given for the Oxford. However, for the fixed bearing, we balance in 0, 30, 90, and also in the robotic it balance in each different range of movement as it was shown. Narrow chisel is required and small C retractors, reciprocating saw just lateral to the at the middle of the tibial eminence, and should not lift the saw for the conventional technique. It will cut posterior tibial plateau. Should not cause the fractures of the posterior tibial plateau in the conventional, which was discussed before, and not in full extension. And sizing of the tibial component, like we reset the tibial component and then check the and different system, whichever system we are using. Sometimes we may not be able to cut exactly, then we will not be knowing the tibial component. Then this kind of instrument, fix the implant, go through around and put the trial and go through around and then size. If you are not cutting the tibial component at one go, sometimes we cut little less, then try to cut more. Sometimes it happens during the procedure. And for the long-term success, femoral component weight bearing centrally on the tibial component. So we mark the femoral component, where the femoral component sits, it has to be on weight bearing centrally on the tibial component. Spacer block should not be tight in and mild varus to be maintained. Let's say this patient, if you are doing trailing, you should have that mild varus. You should not make this varus into valgus. And complete flexion and complete extension should to be achieved on table. And if you are doing mobile bearing, this mobile bearing should not touch the anterior aspect of the femoral condyle to avoid spin off. If you see that this bearing should not, if you in complete extension, we remove this part of the bone anteriorly over the front. Otherwise, this spins off. The common reason of mobile bearing problems is the spinning of the poly, which spins off when it hits the anterior femoral bone. So we remove that bone if we are doing the thing, mobile bearing. With that, you can see that we can get absolute full movement, full flexion. They are able to do all the activities as it was told by the previous speaker. So they can flex, sit, run, do all the activities. Only thing is that our indications and our proper surgical techniques to be maintained. And there was another thing that which patient to do HTO and uni. There is little overlap between this kind of indications. Sometimes here I am seeing one. I had done HTO for one patient, not happy, then I did uni for the other side. So this is the thing which we sometimes go through in our day-to-day practice. Sometimes there is little overlap between the procedures. So here this patient comes with one side uni, complete alignment. There is a instability of the ACL. So did ACL reconstruction, then robotic partial knee replacement, same sitting. So he is now he goes for trekking, he does everything. So he is very young, so I just put this because this is a young arthritic. Sometimes we have to do, but this is one of the rare indications where we do ACL with partial knee. Otherwise, all the fixed bearing, we don't have to do ACL. But if there is too much instability, this is a fixed bearing robotic one, then rarely this was done. So with that, I think this is a robotic. It is already covered. I thank you for your kind attention.